Hi, thank you. My name is James Foran. I'm a medical oncologist specializing in hematologic malignancies. I work at the Mayo Clinic Cancer Center in Jacksonville, Florida. And I'm going to talk about the presentation at the Acute Leukemia Forum that I gave, which is in what patients would you replace 7 and 3 with venetoclax-based therapies? I'm going to focus more on older patients just because that's the greatest area of controversy, and also really where venetoclax-based therapies have become predominant in the United States. I think really also in Europe, and to some extent in Canada and other countries too. Older patients with AML have traditionally fared worse. We know that you can cure some people with 7 and 3 intensive therapy, but the complete remission rates are not as high as younger patients. The induction mortality is higher. And honestly, the long-term results are inferior. You can even get some patients to transplant when you try to about 10%. But the question has been, can we do as well with a venetoclax-based therapy? Can we get as good a remission rate? And can we actually get more patients treated and generalize the benefit of that treatment in this population, who historically have been undertreated because of the barrier to treatment that intensive chemotherapy represents? Now, venetoclax and azacitidine was published last year as a randomized study in the New England Journal of Medicine, showed a clear advantage in complete remission rates, and also a clear advantage in overall survival compared to azacitidine alone. Historically, we know that treatment is better than no treatment, and azacitidine has become the standard in North America, low-dose Ara-C in some places. But venetoclax showed superiority when added to azacitidine, higher complete remission rates. About a quarter of patients, or just over a quarter, actually were negative for minimal residual disease testing by flow. So MRD negative remissions can occur, and a significant survival advantage, which is really the key. Interestingly, some patients, even though they're not meant to be eligible for intensive therapy, improve their performance status or become eligible for transplant afterwards. And so it might even be a vehicle for some patients to transplant. The question is it as good as 7 and 3? And do we know as much about it? One of the key issues is that the patients who were treated on the study are different than the patients who are offered 7 and 3 intensive therapy. They're selected to be ineligible for intensive treatment. So there's obviously going to be some overlap of people who just elect to go on the lower intensity treatment with azacitidine venetoclax versus 7 and 3. But there's a selection bias towards intensive therapy or towards lower intensity therapy. And so we really want to make sure that we're comparing apples and apples in this situation. What are the goals of treatment? Well, getting a complete remission matters, achieving MRD negativity matters, and long-term survival matters. And then there's a question about cure. Are we actually curing people with low-intensity treatment? If you look across studies at patients who got 7 and 3 versus those who got azacitidine and venetoclax, you'll see that there are some difference. You may get higher complete remission rates with 7 and 3, but you get higher composite complete remission rates. That is, people who don't have a formal complete remission, but complete remission with incomplete blood count recovery may be higher with azacitidine venetoclax. The MRD negative rates seem to be higher with 7 and 3 chemotherapy in the range of 40% versus about a quarter with azacitidine venetoclax, about 23% in the recent study. There's always been a concern that the 30-day mortality was higher with 7 and 3, but modern studies show that to be about 8.5%. And that compares pretty favorably with the 7% azacitidine venetoclax. That's not easy for everybody because there's a lot of hematologic toxicity and a lot of fever. Well, not a lot of fever neutropenia, but hematologic toxicity is real. When you look at the median survival, it's about the same, about 14 months for 7 and 3 in a recent study that we ran in ECOG Akron cooperative group in the United States versus about 14 and a half months for azacitidine venetoclax, so very similar median survival. The question is really about the tail on the curve also, and are you curing people with that combination? So I think there are 4 major questions to say, are they really apples and apples? Are these really the same patients? Could they derive the same benefit? Could we treat more people with low intensity therapy if we just started using that instead of 7 and 3? Well, it's important to remember that 7 and 3, it's fit patients versus those who are ineligible for induction. The goal of therapy is also cure rather than just remission and survival. There's a trade-off of hospitalization for intensive therapy versus hematologic support and blood count recovery with low-intensity treatment. And then an important question about the applicability in the community, about comfort with the low-intensity regimens, the ability in the community practice setting to keep people on treatment beyond 2 or 3 cycles, just supportive care in general and blood bank access, and also whether patients can get access to bone marrow transplant facilities afterwards. And when you look at community practice, we know that there are more dose reductions, dose delays, and on average, so far, fewer cycles of treatment, just because it is harder to keep people on. So right now, I don't think we know the answer to that. We can cure older patients with intensive therapy. That's still a bias I have. But for people who have adverse cytogenetics where intensive therapy is not as effective, particularly TP53, it's particularly attractive to try low intensity treatment. There are going to be triplets where we add a targeted agent in specific settings to low intensity treatment to try to make them more applicable, or to adopt a precision medicine model. And I think this has to be a thoughtful, collaborative decision together with the patient to select the right patient based on their age and their fitness and the goals of therapy, access to a caregiver, and their cytogenetic and genetic risk group. I do believe we should try to offer curative therapy whenever possible until we know that we can get the same long-term survival, not just 2-year survival with azacitidine venetoclax. Then I think that we have to be careful about shifting everybody towards that. There may be novel consolidation strategies that we can incorporate with azacitidine venetoclax that make that more attractive. And right now, I think that we need longer follow-up and more prospective data. We're going to get some information from an upcoming EORTC study that's going to report on decitabine versus 7 and 3 to tell us about equivalence. And I think we'll get more comfort with this, but right now I don't think that we can uniformly offer everybody azacitidine venetoclax, and it really has to be based on the goals of therapy and the interaction and decision together with that patient. Thank you very much.